So once again, good evening and welcome to this 116th episode. We have a very elusive speaker. As Sonia ma'am was talking, he is one of the brightest mind in psychiatry that we have. But he has to be chased to be brought into the webinar. So we were able to do that finally. The topic is adult ADHD focus on women. No, sir is a very avid researcher. He's a lot number of publications. We'll just see in the slides. Uh, the how we conduct the webinar is everyone will be on the mute mode. The panelists can unmute themselves. We'll record the meeting and put it on the Facebook and our YouTube channel that is coming up. Those who want to ask questions can raise their hands, can rather put their questions in the chat box. So we'll take questions from the chat box, the moderators, and if the chairperson can also help in that. So next slide, please. I'm handing over the session to the chairperson of the program, Professor Tofan Pati sir. Sir is from Cuttack. He is known for his organizational skills. He has various awards to his credit, organized huge number of conferences, and this program is running under his chairmanship. Sir, over to you. Tofan sir, please unmute.
Thank you, Alim. Am I audible?
Yes, sir.
So, without losing more time, I shall be brief in introducing Dr. Alim and Dr. Amrit, moderators. Next slide, please. Dr. Amrit Patajoshi from Bhubaneswar, Professor of Psychiatry and EC and Direct Council member of IPS and a vibrant psychiatrist, young psychiatrist of India. He is our moderator, and Dr. Alim Siddiqui, the treasurer of Indian Psychiatric Society and Professor of Psychiatry, Eras Lucknow Medical College, also a vibrant and young member of IPS. He is the other moderator. With this, I would like to proceed on to the furtherance of this episode. But I note one thing, please everybody note, Dr. Jagadishan is in Melbourne. It is midnight for him, is it right? And he has been kind enough to spare his sleep for this session. Thank you, Dr. Jagadishan. From now onwards, the meeting is handed over to the chair. Next one, Dr. Sonia Pariyar, our consultant psychiatrist. He is MBBS from Gandhi Medical College, Hyderabad, MD from CIP Ranchi, Director of Dhanvantari Hospital, Raipur, and Chairperson of IPS Task Force and Perinatal Psychiatry, past President, Chhattisgarh Psychiatric Society, past Co-Chairperson and Convener, IPS Specialty Section, Women Mental Health. Actively involved in training health supervisors of State Department of Child and Women Development at Chhattisgarh, invited guest faculty at various national and state semis, honorable awards and achievements, Naika Most Popular Women Doctor in Raipur 2010, Ujaswini Outstanding Lady in the Field of Medicine Chhattisgarh 2017. Welcome, Sonia. And we have with us Dr. Ruma Bhattacharya from Bhopal as the other chairperson, working as a consultant since last 20 years, elected direct council member of IPS 2021 to 2024, international member of American Psychiatric Association, founder of WOW Watts of War, welfare society which works towards creating awareness of mental health. Hobbies, traveling, dance, theater, adventure sports. A graduate in mountaineering from Himalayan Mountaineering Institute, a solo traveler, animal lover, morning start with feeding stray dogs and taking injured animals to hospital. Welcome, Dr. Ruma. And from now onwards, the meeting is yours, Dr. Ruma and Dr. Sonia. Please take over.
Yeah, good evening, everyone. Thanks for such a nice introduction, Dr. Tofan Pati. Sir, as usual, wonderful to have these Thursday musings. I take the privilege of introducing Dr. Jagadishan K from Australia. He is a consultant psychiatrist and director, Northwest Area Mental Health Service, consultant psychiatrist at North Park Private Hospital, chairperson, ADHD Network Committee, adjunct research fellow, Swinburne University, Melbourne. And he has a number of publications, like Dr. Alim already mentioned, in national and international journals. So welcome, Dr. Jagdishan. And I had heard such nice things about you from Dr. Sonia. So now I hand over Dr. Sonia to introduce the topic.
Good evening, everybody. At the outset, I would like to thank the Thursday Musing team, Professor Tufan Pati, Dr. Aleem, Dr. Amrit, for having chosen such an important topic. As we know that ADHD in women is quite an underdiagnosed disorder. In fact, if we can call it the hidden disorder. And I think in the Asian area, especially in the Indian setup, we tend not to diagnose this disorder. So I think this is a very important area, because if you don't diagnose it, especially in the perinatal period, we know what an impact this disorder can have. The disability it can cause to the lady can be tremendous. So I think it will be important for us to highlight many questions which are unanswered about this disorder. You know, we know that ADHD was diagnosed as a childhood onset disorder earlier, but we know it has a lifelong course now. It does have an adult course as well. And in women, the presentation is quite different. And that is the reason I think it was underdiagnosed. I think Jagdishan will be highlighting to us the unique presentation of ADHD in women and how to screen them early, you know, how to identify them in the perinatal period and to address the comorbid issues. We all are aware that ADHD is associated with significant comorbidity, especially with the substance abuse. So treating it in the perinatal period can be quite challenging. And we know many of our women stop treatment. And I think not just stop treatment, first diagnosing it, identifying it, and then treating it. All are challenging, many questions to be answered. And from the research point of view, also, we have very limited data on the treatment of ADHD as such in women, especially in the perinatal period. So I think Jagdishan would be highlighting to us the kind of impact this disorder can have on women, the kind of psychosocial stressors that are associated, the kind of overwhelmed situation women face if they are not diagnosed and not treated, and what is its long-term course. And from research point of view, is there an adult onset ADHD? That also needs to be explored. So I think I'm looking forward to our bright boy, Dr. Jagdishan from ex-CIPN, my alumni. I'm so proud. And I'm so thankful to Aleem to have identified and got him on board, because I think I'm looking forward to listening to him. And of course, we don't waste any more time and give the charge to Jagdishan to address this very important area of ADHD focus on women.
Thank you for your kind words, ma'am. Always, you are always kind. And I also thank Tufan, Professor Tufan and Aleem and Amrit for organizing this for such a long time. And I thank the chairperson Ruma as well. So you have really summarized very well about the significance of ADHD as well as the issues around women. So I won't introduce myself much, but I just want to highlight that I'm part of Royal Australian New Zealand College of Psychiatry binational committee. I'm the chairperson, so I have seen things inside. And I was fortunate to be involved in the ADHD national guideline, which was just released on the 5th of October. So some of the things which I will be highlighting based on that sort of experience, apart from my clinical experience. Some of the questions I would like to cover is why this topic, as Dr. Sonia very nicely summarized. It's a very diagnosed kind of a scenario in women. I don't know much about in India, but a lot of attention in Western media. A couple of years ago, as you can see, negative publicity about ADHD in the media, whereas now a lot of women coming forward and disclosing that having a diagnosis of ADHD is life-changing. Life-changing in the sense that they describe how it helps them to reflect their own life. And it also brings a lot of grief and guilt that they missed out a lot of years of life without knowing what they're dealing with. And particularly in Australia, a lot of celebrities have come forward and produced videos and interviews. And so it's all a massive change. And so there are questions about ADHD in general, actually, why there is a sudden increase in these sort of patients coming to practice. One way of seeing is that there is certainly more awareness Facebook, TikTok, Twitter, they're full of ADHD forums, and people do exchange a lot of information. The other thing is that unlike in many conditions in psychiatry, this is the one condition where there is a lot of controversy. Training is inadequate globally. Even in Australia, the training of ADHD, both in child as well as in adult section, is very weak, hardly anything. Similarly, pediatricians don't get enough exposure. So all of the disciplines who eventually deal with ADHD, they're not trained properly. So it's like a bit of a neglect which happened over years. Now people more aware, coming forward, seeking treatment. And also there is a formation of groups with individuals' lived experiences with the ADHD. They are now voicing more and demanding more access to care. How common it is? In general, ADHD is considered to be more common in boys. That's how it was a bit of it's more like a negative spin on the prevalence, so that girls are seen to be less experiencing this condition. But there are differences in how it presents in both genders. That needs to be kept in mind. As people mature, the gap between men and women tends to disappear. I will highlight some of the scenarios which I have experienced. The reason I thought of doing is, instead of making it like a fully academic didactic lecture, maybe highlighting some case scenarios from time to time will help to reinforce the clinical aspects attached to it. These are the scenarios I will discuss a little bit more. As you can see, there is a 17-year-old young woman presenting with school refusal, poor school performance, and dissociative episodes. So she just came for attention for these problems, not for asking for ADHD diagnosis. And there was a successful female doctor in her mid-30s, mother of two, seeking treatment for persistent depressive disorder for years, who was on 2 antidepressants, undergoing psychodynamic therapy, eventually being diagnosed to have ADHD and also high functioning Asperger, high functioning autism. Another psychologist who practiced within disability sector for years, diagnosing disability and certifying, later herself found to be being assessed for ADHD because her generalized anxiety disorder wouldn't go away even with a combination of medications. Then there was a very famous young woman presenting for the first time in crisis, which was conceptualized as a borderline personality disorder, and in the setting of also PTSD due to sexual assault. But interestingly, the assessment reveals more about ADHD later. So as you can see, it can also coexist with people with severe mental illness, where there is a bit of a skepticism about prescription of medications and late diagnosis. Geriatric population is under-researched as well, even in women, and a lot of people feel that they're highly disadvantaged group. In general, as we can see, the prevalence of ADHD has been an increase. This is one of the famous study from JAMA. The rate has nearly gone by close by 4%, but increased rate also means that there is increased referrals, increased assessment, increased awareness. It's not like the illness is occurring more often, it's more being discovered. This is a very complex table, but I would like to highlight, if you can see, the red point here, which is a last point of data collection, 2015 to 16 in this study. As you can see, in both genders, there is an increase in the rates, but still there is a massive gap between boys and girls, nearly double. So what are the issues in terms of clinical presentations? Why there is a delay in diagnosing like in women? Some of the points worth considering are that the typical understanding that ADHD means somebody is running around, climbing things, climbing chairs, climbing trees. That's a norm. A lot of people still have it. When we apply the same prototype to women, it doesn't apply. they have more of inattention issues, which manifest like disorganizations. The second common thing, which I have also seen, is a lot of self-esteem issues. They are prone to experience anxiety and depression, and they also develop, some of them develop personality issues more around either perfectionism kind of traits or borderline kind of traits. And the substance use, again, more common, mostly around self-managing symptoms. And a lot of internalizing disorders are more common in women than in men. As you can see that even the impairments tends to be severe, but they develop certain compensatory mechanisms which carries them through a point of time when the demands are exceeding their cognitive capacity, then the illness starts to manifest. Other thing is to consider is the effect of estrogen. Estrogen regulates dopamine and serotonin levels. At the points of a time when the estrogen levels go low, naturally the dopaminergic system will go low, where the symptom gets more worse. Particularly in the luteal phase of menstruation, as Dr. Sonia was saying, postnatal period and perimenopausal and menopausal period, all of them are periods marked by low estrogen. So people experience worsening of symptoms, unmasking of symptoms, and each period brings its own psychosocial dysfunction. So if we just going back to the scenarios which I put forward. So the 17-year-old girl was later diagnosed with ADHD combined type, borderline personality disorder, and Asperger disorder. Interestingly, she has a brother with ADHD and ASD, and mother has ASD. So you can see that the genetic side is very, like there is quite a bit of genetics involved. On the female doctor side, again, the ADHD predominantly was inattentive type. She had a bit of a medication-induced mania. She was prescribed a combination of lisdexamfetamine and guanfacine, and she presented with the mania to the hospital. And she has both sons with the ASD. Interestingly, she used to refer a lot of patients to mental health system. Her practice is very close to mental health system, but never had an opportunity to explore this diagnosis until a couple of years ago, when her sons were starting to be diagnosed to have developmental disorders, including they were screening for ADHD. The psychologist who was doing assessment for disability, including ADHD, didn't realize until her children were assessed for both ADHD and ASD. Then she realized why my generalized anxiety disorder is not going away. Very compliant. She knows all the psychological strategies, very good with medications, she's on high doses of the medications, but she has a very good psychiatrist, but still things were not improving. And the sports person, as I mentioned, people labeled her as a patient with complex PTSD, borderline personality. Then she brings a lot of symptoms of inattention, disorganization, and getting bored easily in relationships. So she never had a lasting relationship more than 6 weeks, except the most recent relationship. Even that was prolonged because the person was very interesting, according to her. And the young woman on disability pension and schizoaffective disorder, she was conceptualized as a very difficult patient. She was waiting to be admitted in a prolonged secure extended unit. She was itinerant, she wouldn't cooperate. She was extensively using methamphetamine and cannabis. So when she came to our unit, we had access to collateral information from her father, who was very good in narrating childhood history and tracking school information. And we were able to then diagnose ADHD. And interestingly, she had ADHD. As a result of ADHD, when she was on an overseas trip, she had a head injury, and that complicated her presentation. And the 62-year-old lady, she came with, again, generalized anxiety disorder, difficult to engage with professionals because she thought she was not being understood, and also coexisting depressive disorder, being on 2 antidepressants, tried many other antidepressants, mood stabilizers, none will improve. But then there is underlying undiagnosed ADHD for a long time. Susan Young is a very popular researcher in the field of ADHD, and she has supported the development of ACE, which is an instrument for diagnosing ADHD in children as well as ACE plus in adults. So they coordinated a guideline based on experts, and it's a very good document to have an understanding of some of the issues what we are talking today. In general, the assessment process of ADHD in women is not different to ADHD in general. So there are three components. So one is a clinical assessment component. Sometimes this part tends to be minimized. People rely heavily on rating scales. With the rating scales, many of them are self-rating, even though they have a good level of sensitivity and specificity. There is a risk of bias coming from that, like people particularly help seeking. So a clinical assessment needs to highlight a good amount of developmental history, exposure to perinatal events, genetic factors, and also social engagement, and obviously school performance, and other issues in relationships, emotional regulations, that needs to be highlighted in clinical assessment. Over the time, one will learn to realize that certain questions have a high chance of bringing the response towards ADHD. Rating scales, many of them are very useful, particularly, for example, ASRS, very commonly available, and one can use Conners rating scale or Underwater rating scale or Jasper Goldberg rating scale. I generally tend to combine two of them, even though it's a bit of a overkill. Because of the controversy around ADHD, I want to be more careful. If the screens support, then I take a little bit more time to do the structured assessments. In adults, the preference I generally use DIVA, which is a structured diagnostic instrument, DIVA 5 or ACE+. It takes time, but it also helps to get more comprehensive information and collateral information. This collateral section is very important. In Western world, where there is a bit of a family disintegration, then it's very hard to get the collateral history. Then we need to rely on partner history or somebody who knows the person for a long time. School records, what happened over the years is that the older school records from people coming now in their 40s and 50s, that is very clear and explicit and candid. But the most recent school records are very politically correct. So you hardly get any information actually saying that whether they have any behavioral issues. So we need to consider the current milieu where these reports are written as well. So that sometimes you might wonder that nothing in the school record, but the person is coming and saying that they struggle. So we need to take that into consideration. So just to highlight some of the points, as the severity of symptoms will be different between men and women. I have seen generally women coming like they're functioning at some level, but suddenly the demands exceed their cognitive capacity. Then they present usually with anxiety and depression, not with clear-cut cognitive symptoms, executive dysfunction. Then we need to uncover those things. And the other thing you need to remember also is that disorganization is one of the common presentation. Then say loss of focus, disorganization, and spaced out kind of feeling, and feeling like they are in a dazed state. These are very common kind of experiences. I would also like to highlight that gender bias in teachers and parents. That seems to be an issue in the school reports. They tend to minimize in girls and compared to boys. And also there is a risk of referral bias in women and girls, that The referrals won't happen until the later part of the time. Particularly, the mean age of diagnosis of ADHD in women is around mid-30s actually at the moment. Comorbidity, very highly comorbid. ADHD itself is very highly comorbid, being a neurodevelopmental disorder. In women, it tends to be more internalized kind of a disorders, which common, which I mentioned before. Whereas in men, it's more on the externalizing behaviors. And the impairments and risk of substance abuse are also quite common for both men and women, but intellectual impairments are more common in women. The emotional dysregulation, this is another very upcoming bit of a topic where it brings a lot of controversies. Particularly, it goes into the realm of borderline personality disorder on one hand, bipolar affective disorder on the other hand. There is a lot of literature around differentiating emotional dysregulation or interpersonal sensitivity in ADHD versus borderline personality disorder. Careful history taking really helps. And also there is a bit of an interaction between these two things. When children have neurodevelopmental disorder like ADHD, they are prone to experience more trauma. The trauma itself can increase the risk of developing the borderline personality kind of a structure. So they can go hand in hand. But emotional dysregulation can manifest like interpersonal sensitivity in relationships. I've seen women coming and telling that my partner says something and I get so upset. I don't know why I get that sort of intense emotional reactions, and then later feeling guilty, and so they find there is a degree of a lack of control over the emotions. Other issue with the girls is that they're prone to be bullying. They have low self-esteem, so they don't report anything, and they are also prone to experience childhood sexual assaults, and they also tend to be more sexually active compared to their counterparts. Before coming to the management, I would also like to highlight that it's worth the screening. When we do the assessment, it's worth the screening for comorbid conditions through, for example, ACE+, it has a very systematic way of gathering comorbid conditions. Even if you forget to ask in a standard clinical inquiry. Whereas DIVA has exclusive focus on ADHD symptoms alone, it's very thorough and detailed. So you may need to use another instrument to capture the comorbid symptoms so that we don't miss out. Managing comorbid symptoms sometimes also improves overall outcome when we are managing ADHD in women, both in men and women as well. So I want to highlight the interventional aspect. So management principles, mainly it's multimodal, integrating pharmacological and non-pharmacological treatments. And pharmacological treatments, there is no gender difference in terms of choices of intervention. But certainly we need to give preference to individuals' values, their preferences, and supports available to them so that we can develop a very comprehensive plan. I have seen after diagnosis, some women say that it helps them to understand what they've been through, and then they don't want to necessarily pursue the path of medication. They just want to explore more psychosocial interventions. That's all right. And empowering them and help them to make the decision whichever way is more beneficial. And also we need to take into consideration of the degree of impairment. Some of the sections I just thought of highlighting. So if people are unsure, they can refer this guideline. It helps to orient people towards how to start, manage medication and the medication choices, the range of them, and what are some of the basic monitoring we need to do, and how to improve the adherence, and etc. Are there anything in particular towards women? I don't think so, because none of the guidelines, be it of NICE or be it of Canadian guidelines or other guidelines, there is no enough coverage of women-related issues. So that's a criticism for all of these guidelines. And Australian guideline has received similar feedback. So there is a plan to develop a bit of a supplement, which will probably cover that particular aspect. So medication choices are the same, like below 5 years, mainly very careful approach for the medications, go for the more parental interventions and environmental modification, etc. 5 to 17, the Australian guidelines essentially recommends we can use either methylphenidate or dexamphetamine or lisdexamfetamine, which is slightly different to NICE guideline. I'm not sure whether lisdexamfetamine and all available in India. And the second line is atomoxetine and guanfacine. And it's similar to adults as well. There are a number of other second line medications we can see here, ranging from some antidepressants like bupropion and reboxetine and venlafaxine. Clonidine is mainly used in children, but it's in adults, it's more useful for sleep-related issues. And modafinil, as you can see. I've seen lamotrigine very useful for managing emotional sensitivity, but the literature around is weak. Then you see a number of other medications as well. So when we manage the comorbid conditions, it's better to tackle them simultaneously. But if it is a psychotic or manic episode, then we need to stabilize it and then try a non-stimulant medication. If we need to really try a stimulant medication as there is no response to non-stimulant, then we need to try a lower dose and get a second opinion or get another perspective. And again, eating disorder is quite common in women, particularly binge eating disorder and ADHD. And many of the stimulant medications can have a huge impact on appetite and the further weight loss and feeding into anorexia kind of a symptom. So need to be careful. Risk of diversion is both common in men and women. And particularly when there is a substance comorbidity, we need to be very vigilant about that. And use of modified release, like slow release medications, will be very safe in that sense. For any age in general, we need to provide regular follow-ups and use measurements to capture the improvements. And particularly in young population, we need to monitor the height, weight, and growth, etc. So pregnancy and ADHD medication, there is a limited research. In general, there is a recent systematic study that shows that no increase in teratogenicity, but literature also says that particular amphetamine is less safe than methylphenidate. ADHD medication, there is a question whether it increases the risk of ADHD in children. So ADHD brings more children manifest. Sorry, there was a bit of an internet issue on my side. My apology.
Yes, sir, you are back now.
So coming back to the final, the treatment outcomes. So all these scenarios, you can see.
Jagdishan sir, last few lines from the previous slide.
This one or?
The previous one. Yeah.
Yeah, I think I talked about this, how there's like management of comorbid conditions, what things we need to be careful. So CPP, it's about clinical practice point. And CPR is like, it's some CPP, it's also error. So it's like a point consensusly developed by the committee. We talked about this, and I briefly touched upon about the medication side of things. So this is the final kind of a table. So in each scenario, all these women who presented with not ADHD itself, when they were diagnosed eventually and treated properly, there was good outcome and recovery in both primary presentation as well as overall functioning, and particularly relationships as well. That's all I have to say today. So to sum up, ADHD in women is more underdiagnosed than men. And the usual presentations are around anxiety and depression. And substance use is another common problem behaviors. And personality often can be a presenting point as well. And these individuals are more prone to have a history of childhood sexual abuse and PTSD. So when there is a limited response to treatment with standard approach, it's worth exploring underlying cognitive disorder like ADHD, and we need to be mindful that the symptoms will be somewhat different than what we typically expect. So I will conclude the presentation here, Anim, and I'm happy to take up questions and talk.
Thank you so much, sir. You can stop the slide share now. Over to chairpersons for their opening remarks.
Yeah, thank you, Dr. Jagdishan, for the presentation. I would like to understand that regarding the pharmacotherapy management. So stimulant medication is one of the widely used treatment in the management of ADHD. But there are frequently reported adverse effects also, like decreased appetite, headaches, abdominal discomfort, irritability. So patients usually seek alternative treatments as well. So can you comment if yoga is helpful as a therapy in ADHD in women?
We did review literature. As I mentioned, I was part of the guideline group. When we reviewed all the non-pharmacological evidence base, nothing came very close to recommend except CBT. Even CBT, it's not a general CBT. The CBT needs to be tailored to target some of the ADHD specific symptoms. Like, so I can't remember we had enough evidence to recommend yoga in that sense. It might be helpful to manage some of the coexisting disorders, like by reducing anxiety might improve the cognition, but direct improvement in symptoms, we couldn't find any evidence to recommend.
Okay, and also has vitamin D any role? Sorry, continue, Dr. Sonia.
I think when you raise this question about management, about non-pharmacological interventions, like Jagdishan very rightly pointed out, CBT has to be tailor-made for ADHD, especially the prioritization and the time management and that intense emotional dysregulation that females face. They're very short-lived, but they're quite intense. And I think practical issues like what you pointed out, Jagdishan, like methylphenidate, most data says it is not teratogenic. Though the data is limited, I think we can get very good results. But then treating comorbidity along with it, sometimes with bipolar disorder, can be very challenging because you can't do too much of polytherapy, especially in the perinatal period. But then, yes, it appears to be quite a neurobiological disorder, very heritable. And of course, there are environmental factors affecting. But Jagdishan, do you think that the recent research identifying that adult onset ADHD, women being diagnosed in the geriatric group, the case that you saw, then women being first diagnosed only in the perinatal period, is it the same childhood disorder that is continuing, which we have not diagnosed early, or it is a totally different onset of a adult onset ADHD? I think these are the areas which are really mind-boggling, and we have to identify them. What's your view on that?
When I started to get into this ADHD space, my doubts were around that. How come late onset ADHD? But then through experience and involving with colleagues very experienced in this, it's a lifetime disorder.
Yeah.
It's a lifetime disorder. People have it. But people who are intellectual, who are smart with high IQs, they compensate for other cognitive issues by developing good routines and also particularly if they have good structures in their life, like a good parenting, schools very strict with the expectations, the deadlines and timelines that keeps their adrenaline system kicking, so they don't fall back. They do really well until they get into less structured environments, particularly universities, and where there is more self-reliance is expected. And as they go into more intimate relationships where they're expected to be self-reliant, when the scaffolding falls away, when they need to be on their own feet, again, they start to experience more internalizing kind of symptoms, some sort of dysphoria, anxiety, depression. As they get into having children, it's more dysregulated because they can't manage this. Because the kids have their own way of doing things, their cognitive capacity gets really exceeded. That's the time the syndromal features manifest. That's what being thought to be as a late onset, but actually it's a late manifest ADHD than late onset. And it can range for some people. It's until their 40s and 50s. Very successful people, very successful. Like people leading their organizations. Then they slowly tell bored with mundane things, and a lot of arguments happen. Then you realize that demands what they're facing at that point in time is beyond their cognitive capacity. So that's my thinking around this dilemma of late onset. Literature, there are people who say how late onset. I think it's a late manifest. It's being a neurodevelopmental disorder. It's not a neurodegenerative disorder. So it has its own hidden signs. Like there are electrophysiological studies, and still they are trying to find out some biomarkers, but they are not very consistently coming up. But certainly the clinical features, when they manifest, they're fairly consistent.
So can we take the questions from the chat box? Ali, would you be doing that, or Amrit?
Sure. I can do that. And if Ruma wants, she can also chip in. So many questions regarding this borderline personality and ADHD overlap. There are too many questions. How to differentiate this mood dysregulation, where lying. Suppose borderline personality is diagnosed more, so less of medications would be offered. If ADHD is diagnosed, chances of getting medication is more. Dr. Subhash has asked. So these things regarding borderline personality traits or personality disorder, ADHD, and the mood dysregulation. So how do we clinically differentiate? and how do we treat it accordingly?
So one thing is that we don't need to consider them as, say, exclusive conditions. Like if one present, the other doesn't present, they can often coexist. There are a lot of environmental epigenetic factors. Like as I mentioned, people with ADHD or neurodevelopmental disorders in general, and their social environment when they grow up is often negative. And so these kids are exposed to several forms of trauma. And that trauma itself leads to attachment issues. As a result, there is a separate attachment style and interpersonal relationship issues developing simultaneously. The literature on emotional dysregulation versus emotional, like interpersonal sensitivity, again, there is a fine point saying that in ADHD, if it is pure ADHD, the person has a difficulty like self-regulating. It's like it's a biological disorder. So there is a difficulty self-regulating emotions rather than self-regulating emotions to stressful things, which happens in borderline personality because it's more targeted outside. It's a response to the environment, which is common in borderline personality than a biological disorder. So the same with even bipolar disorder. In ADHD, people are more excited. They are always excited. They are creative. Their mind is racing. And there are studies exploring the strength of ADHD. And people with ADHD, they say that they are very creative. They can think number of things parallelly than any other people. So they are always excited. Whereas in, say, in bipolar, it's like it's a periodical kind of a phase-dependent kind of a change, which is out of sync with things happening around them. So the borderline personality often can coexist. Some of my colleagues strongly believe that if you treat ADHD, borderline personality basically disappears. Maybe that can happen to a small percentage of people. We don't know the exact data. And there are people who completely negate. People can have ADHD when they have a BPD, like a borderline personality. So there are different views, but the main thing I would say is that they can coexist. They can always coexist. The treatment of coexisting conditions is that we apply the management of treatable conditions first, like ADHD can be treated somewhat quickly with medications. The evidence for the medication response to stimulant is very high. And the effect sizes are much bigger than any other therapeutic medications. And you know that the response happens fairly quickly. Within a couple of days, the person sees a change, unlike they need to wait for weeks and weeks with antidepressants. And so treatable condition like ADHD, once we treat, that's what I say to people, like, let us treat the ADHD, then see what is left out. Then left out conditions can be managed through the same way of managing. If it is needed, we use like a DBT or acceptance commitment therapy or offering other form of psychological tools. Often mindfulness, etc., will be beneficial to manage the left out personality factors. More than BPD, people also have perfectionism. Very smart people, they have a very perfectionist tendencies, and they're very hard to be tolerating other people. So that also often brings us an issue like a obsessive compulsive kind of a personality traits.
Okay. Sir, suppose a clinician is sitting, a general psychiatrist is sitting in the OPD. So what you have covered is in the presentation also, I'm just repeating. What are the pointers towards ADHD in a person who is presenting now with depression, with anxiety, with other mood disorders? So when should we get alarmed that a person might be having ADHD? The ADHD is not full blown. It is support partly it is there. So how do we arrive on the conclusion that a person would be having ADHD? It is a repetition you have already covered. I'm just asking for the sake of audience.
So to summarize, I would say that typically the response rate to any first line antidepressant is only 50 or 60%. So generally, most people end up having a second trial. Even after second trial, there is a degree of not much improvement, or when people are on combination therapy, still they are not improving, then it's worth exploring screening. What we need to remember, then the prevalence is about, for children, it is about 5 to 7%. And for adults, it's around 2.5, like a 2 to 3%. 2 to 3% is much higher prevalence than schizophrenia and many psychotic disorders. So it's, and particularly when it's undiagnosed for a period of time, a lot of people may have it. So it's not a bad practice. Once we feel that the typical treatment is not helping, start to screen and refocus into developmental history, so that there is, particularly when they come to like a psychiatrist and tertiary centers, they would have already went through some of the standard approaches anyhow. So that's my thinking. I think Sonia madam might have something to say.
I think you're quite right that, early diagnosis can be done. I mean, we are seeing a patient is not responding, like Aleem pointed out, but going back into the past history, the performance in school, as you had pointed out, how are the school reports? That's a very, very simple question. I think all of us should delve into, going into the past history. Early diagnosis, one of the best ways to take a good history of the early childhood, because most of these disorders have, ADHD has an onset in the childhood, as we are understanding. So screening at school level, taking a history about what was the child's performance in school. Many people say retrospectively, they may not recall, but I think you can ask leading questions. There are some retrospective scales also available where you can delve into, and that could give you a clue. So if a patient is not responding, it's easy to identify anxiety and depression, but underlying ADHD can be picked up by taking a good past history as well. So I think we should focus on that, because the diagnostic criteria are not dealing, ideally helping us identify. We know DSM has now changed the criteria a bit, age of onset from 7 to 12. Number of criteria has also been reduced, and even if you have 5 associated symptoms, you can diagnose, but they're not helping us much in our clinical practice. So I think going on to early history is very, very important. We should always ask for childhood history. We should make it a routine, because this 1-to-1, like you said, incidence in women is equivalent to male in the adult age group of ADHD. But I think that could be a misinterpretation, because we have missed out diagnosing it much early. So early diagnosis, identifying it, childhood level, taking histories is very important. I think in Australia, they do it quite regularly. In our Indian setups, we don't have such facilities in our schools where a child is being monitored so closely. That's a big drawback in our setups. I think you have a much more structured setup in Australia. That's why it's being diagnosed and identified earlier there. I think we too need to be alerted to that.
Okay.
Yeah, go on, please.
So there are a few questions on the medication part. So Amit Banerjee sir wants to ask that what he can recall is stimulants do not cause difference in long-term outcome. So is it true, or is it, what is your comment on this?
I'm not sure where that is coming, but I'm trying to recollect whether I can cite any particular thing. Once you treat them, there are people who stay for years and years with stimulants. So one of the worry about stimulant is the risk of abuse. People talk about it. The risk of abuse is very limited, very small compared to when we give it to people with the right diagnosis. Like they don't develop tolerance. They just use it, they mature it. I've seen people taking for years with much better functional outcome. So I'm not sure whether that holds true. Rather, people feel that they missed out, that this was not done before. Their career could have been different, their life could have been different. That sort of a reflection often people have. And interestingly, one thing what I've seen is that often it brings a bit of a grief process, particularly when they realize that they could have been somewhat different. The grief, they go through really terrible sense of loss and despair and anger before they come to terms that they need to work with what they have. The problem in adult is that certain behavioral patterns are more or less set when they fall into adult age group. Then it takes more time to rectify them. That's the reason earlier catching up and working through them really helps to prevent more bad outcomes in adulthood.
Okay. In fact, Dr. Ranjan has just posted that he's recently encountered a patient who is taking MPH 54 milligrams per day, 3 times the prescribed dose in a 16-year-old child. And the child is repeatedly insisting on getting that because he has been prescribed from the Central Institute. So he wants any comments on this. The people who are actually using it excessively, what to do there?
So the literature, there is quite a bit of literature on diversion. There is a substance use disorders. They basically give it to other people, they sell it. And there is very commonly often diversion happens within the family where, because it's a genetic condition, somebody else tries to take to see whether it improves the performance. The third largest area where it happens is within the academic settings like universities, where there is a bit of a peer pressure, bullying, so that the individuals with the, on ADHD medication, they give it to their peers and they do report actually. It's quite a bit of studies being done. And particularly if there are substance use peers, and they really demand and create trouble for these individuals. So when we realize that, at least in Australia, we have a system called SafeScript, which is like a centralized system, which monitors which basically approves only 1% to prescribe. And every pharmacy and doctors need to check the SafeScript system to see whether the script was given before or not. And there are doses. Some states, they're very strict about dosing. In some states, they're liberal. But what we need to remember is that there is a risk of pharmacogenetic variation between these individuals. Methylphenidate actually doesn't go through first pass metabolism. It goes through more of a second pass metabolism. So the variations are less. Mainly DEX can vary. So if somebody is needing more and more, I think we need to explore environmental factors and restrict their access. And here we do like a daily pickup or every second day pickup from the pharmacy, or some sort of supervision by people like family members, or that sort of a thing. And if we really worry, then we need to stop prescribing and go for non-stimulants.
Okay. So there is a add-on question regarding MPH. Likelihood of precipitation of micropsychotic episodes in borderlines.
Yeah, I can't comment any literature, but in general, there are studies about psychosis risk during stimulant therapy. And the risk with methylphenidate is really marginal, actually. There are very big studies. They are published in very good journals. Dexamphetamine is slightly higher risk, but methylphenidate is it's a very negligent kind of a risk. But there are individuals who develop. I have seen somebody developing more paranoia on methylphenidate. Most likely they abuse. They don't tell us, but they take other substances, or they take extra doses from time to time. That does create, particularly when there's a bit of a genetic background.
Okay. Answer for mood regulation in adults with bipolar. For mood regulation with adult ADHD, what is preferred, mood stabilizer or antipsychotic, and any specific molecule?
Usually the stimulant fixes it. The mood becomes very easier actually with the stimulant therapy. The next line is, before we go into that, then we try the mood stabilizer in case if there is no enough improvements. Lamotrigine is less research, but clinically a lot of my colleagues also find it very beneficial. It's being a cognitively safer mood stabilizer compared to many other mood stabilizers like lithium or sodium valproate. And it's not weight inducing or has a less metabolic risk. So it's a lot more safer to use. And there are people report very positive outcome.
Okay. Dr. Amit Banerjee is here. Sir, please go ahead.
No, I've put all my questions in on the chat. I'm fine to stay silent. If Dr. Jagadishan wants to answer some of them, that would be helpful. I say that all diagnostic criteria are useless, and basically anyone who takes stimulants will have a time-limited improvement in focus and concentration. I believe that they're essentially addictive drugs. Yes, the potential for abuse is not as much as I used to think 15, 20 years ago, but it is still there. Human beings are complex. They have complex personalities. This overlap between borderline and ADHD. And the whole I say this neurodevelopmental disorder, well, why is it being diagnosed in 30s and 40s if it is neurodevelopmental? It should be diagnosed earlier. So essentially I'm saying that, why is there a demand for stimulants in universities, before exams? So why is there a street value for dexamphetamine? So these kind of things, and it is spreading like wildfire. There is no very poor diagnostic validity. There are no long-term studies on the outcome. There are studies saying that when they are started in adolescence, the outcome peters out. Actually, the functional outcome, even recently, UTech Sydney has published a study saying that, the outcomes are worse. So people should be cautious. And I also say that ethno-psychopharmacologically, I think Indians are different. I say that, this whole business about membrane permeability, stabilization, whatever, I don't know, biology in a big way, but I say that, the chances of psychosis, I have worked in India. I've seen acute psychosis in India, as all of you have, and I've seen psychosis here too. Sometimes psychosis can be acute here too, but, there is some kind of difference, and, someone has made the comment that, how do you look at literacy? How do you sort of diagnose it in illiterate people? I mean, this is very valid. So I am contesting this issue about the diagnostic validity of ADHD. I accept that there are useful medications. And as a private practitioner in Australia, I have to do a service to the GPs. 8 out of 10, 9 out of 10 of my referrals are for ADHD. And I don't even advertise. I do, 1.5 days of practice. It's like my wait list is out to 100. So, so I think we should really be careful before we blindly ape Western countries. And there are some regulatory processes around, as Dr. Jagadishan mentioned. In India, there will be none. And as Dr. Bhattacharya talked about his patient, people will be demanding more and more. Here also, they do the same. It is a tricky business. Anyway, sorry. I hope I have not digressed.
So I think, Dr. Amit Banerjee, I have a different view on your restriction part. Methylphenidate, still in India, you need to keep a copy. You need to take a license. It's not easily available. And now your question, whether Indians do not have it as much as the West, is it that we are not diagnosing it in time? Or is it that actually we don't have this disorder as much because we are not identifying this disorder? I must humbly admit, being a private practitioner, ADHD in young age group, we are seeing quite often. But in adults, I think many of us would agree that we are not diagnosing it. So is it because we are not diagnosing, or is it doesn't exist? Is there a difference between the Asian population and the Western? I think, yes, there are more questions than answers. But yes, there are a lot of restrictions on availability of stimulants in India. You cannot prescribe. You have to still keep 3 copies. You still have to take a license. It's not that easily available.
Yes. So thank you, Amit. Yeah. So I think what Amit represents is a lot of people can relate to Amit's perspective. So the core thing what being left out over the years is that there is no proper training. Like people pick up the skills along the way. So that's where the question, a lot of questions come amongst the different views. And medication, like we call it stimulants, by in my perspective, the name itself is a misnomer. They basically dopaminergic agonists, or they work on monoamines. So it's better if they're like a cognitive enhancers because they target cognitive executive functions. And the positive emotions which happen, they are very brief lasting. What we are seeing more like a cognitive enhancement. So I think that has attached a significant stigma, even though stimulants were introduced 70, 80 years ago for different reason actually. So stigma is a big factor, and the sudden demand really confuses practitioners, and particularly when they're not enough training. And as I mentioned, none of the streams, be it of allied, be it of psychiatry, be it of pediatrician, there is no systematic training both at a child or adult level. Then they suddenly need to pick up whatever available. So I think it really creates a big systemic problem.
Dr. Jagadishan, like the training, whatever training we get, the training is always geared towards diagnosing more and more, lowering thresholds. I mean, inattention is a dimensional construct. You know, I mean, and we are trying to fit these things into categorical boxes. You know, it is generally accepted that, girls will not have hyperactivity as much as boys. I mean, the gender bias is, starts from there. But inattention is a dimensional construct. I have prescribed stimulants to adults who you would not even think that they had, well, inattention is a very difficult one to say, but when is a person inattentive? However, if that person, the general feeling that you would get would be that this person is shy, social anxiety, not completing his tasks, everyone wants to, like, it's a rat race. It is the human society is a rat race, and everyone's running to go, to get ahead. And stimulants are a little small sort of element that help some people most of the time. I have to admit that they're helpful medications. They are pretty helpful medications. However, they have their dangers. And I think this, this diagnostic, these guidelines, which kind of say that, or go up to the dose, which is effective. I think that those kind of ideas are dangerous because I have seen enough overvalued ideas, not really psychosis, but I can say, I mean, last week I had a woman who was on 50 milligrams of dexamphetamine. And I can't say that her life was any better than, when I didn't, obviously she came to me for the first time, but, she got very upset when I said that her previous psychiatrist was giving her a 6-month supply of 18 bottles of dexamphetamine, 1,800 tablets, and just letting her go on a regulation 24. And I said, I cannot do that. I will only supply monthly scripts. She got upset and started crying and saying that I was interrogating her. So anyway, I mean, so it's all, illness is a social construct. Disorder is, something that, a cluster of signs and symptoms that we find that happen more often than by chance. I contend that this is not a neurodevelopmental disorder. I think those who are creating these guidelines are self-interested professionals who basically want, the Psi professions still advance. And this is what society wants. As I say, I do not advertise that, I do ADHD, but 85% of my own, and 90%. And what can I do? Let's say borderline personality disorder comes. I mean, what can a private practitioner do anyway? So this is the story. I mean, I'm sorry to sort of vociferously throw in such words of maybe, I hope I have not burst anyone's bubble, but this is the truth.
No, that's okay. No, I'm saying that there are controversy around it. So that's a reason this condition has been left untouched for years. Can I comment about this attention issue? So one thing which, so inattention, it's a construct, as Dr. Amit says. The issue is it's not about inattention. Often people have difficulty regulating attention, where to focus, where not to focus. Certainly, a lot of them have periods of hyper focus. They do certain things for a very long time, actually. And where some of them have issue with the time, their concept of time is different. That's one of the symptoms they often say. So they miss the deadlines, they procrastinate. And so often there are people say it's a disorder of regulating attention. It's not a really inattention. So I think with the time, when there is more and more consistent research emerges, it will help to characterize it. We still hold on to the very rudimentary definitions. That's the problem. Even the emotional components are not being included in the current diagnosis.
So that's why it is said that they can't work a plan and can't plan their work. So
until there is a last minute challenge, then they get up everything.
Yes. I have a question. Can I? Moderator, please. Yeah, I just wanted to know that, of course, ADHD is a multifactorial disorder and definite etiologies are known. But vitamin D has many functions in both developing and in adult brain. So do you think that vitamin D deficiency is associated with a wide range of neuropsychiatric and neurodegenerative disorders? And does it help in ADHD?
I have no specific literature to cite, but when generally we reviewed the literature, except say fish oils, there are some beneficial effects, but none of the other supplements and nutrition has been found to be specifically useful for the symptoms. That's my understanding. But I do recommend people to take a vitamin D, but generally because when there is a lower, there is obviously anxiety and depressive kind of symptoms go along, and there is a sluggish cognition. But whether it leads to a syndromal ADHD, I'm not well aware.
Okay. And what about the parathyroid hormone levels?
We check the thyroid. Obviously, when an evaluation happens, we try to rule out all the neuroendocrine disturbances which could account for general cognitive dysfunction. So again, thyroid screening, we check also parathyroid, but it's not very specific.
Okay. Yeah, okay, Dr. Sonia?
I think, Jagdishan, you gave us a very good outline. But to sum up, I would like to, especially the younger lot who's listening to this talk of yours, and Dr. Amit, my senior resident, who is very vociferous about the very existence of this disorder and especially the adult variation. But I think putting things in the right perspective, this is a very disabling disorder. It should be identified early. The earlier you treat, the better it would be because of the long-term impact of this disorder on the functionality of the person. I think this fear about using stimulants, we all know that we have enough data that methylphenidate is a very efficacious molecule, especially when used at an early age, when identified correctly. The controversy remains is how long do you continue the stimulant, and if you're diagnosing it in the adult age. That is the area where there is some controversy, I agree. But as far as women are concerned, I think they are missed. We have not diagnosed them early. So if you identify them later, I think we should address this attention deficit. Use of stimulants, if you're sure you have diagnosed it correctly, you have a past childhood history quantified that yes, she had performed poorly in school and now she's getting overwhelmed when she is facing many more tasks, like Jagdishan pointed out, in marriage, or when the support systems disappear and when she's given more tasks to do, she can disintegrate and even have some micropsychotic episodes. So I think one should not have such a negativistic attitude towards the use of stimulants judiciously. Identify the disorder early, be confident of using it. I don't under-treating it in childhood, I think it will be a disaster. And the other points that you need to know that in women, the mortality is much higher. The driving skills are impaired, the cognitive skills are so impaired during the peripartum period. We need to research this area and maybe doing research in the peripartum area of ADHD. I think that's one area we all need to focus. That would give us some clues about this disorder. This basic question my senior has raised, that is it a neurodevelopmental disorder also or not? I think that's a very big controversy. And I think I go by the thing that it is a disorder. It is a neurodevelopmental disorder, definitely. Identify it early, treat it. that is my view as the chair for today's session. But I think I'm glad that Dr. Amit has raised these issues so that it stimulates our young brains to research in this area and make it more clearer about the guidelines.
Thank you so much.
Girls are diagnosed less because girls present less with disruptive behavior disorder than boys. And that is why boys in childhood are diagnosed more and treated more. And the disruptive behavior disorder in girls is less. And like doctor has already mentioned that girls present with more of attention problems and internalizing problems. So it is detected later in life, and definitely it has to be identified, treated, and diagnosed and treated in time. That's what I have to say. Yeah, Dr. Aleem.
Thank you so much, chairpersons. There was a question that do we need a separate license for prescribing stimulants? I don't think so. You just need to have a copy with you.
You need to have a copy, but the medical shops which are giving this medication, they need to have a license.
Yeah. They need to have a license, and you need to keep the records of it.
Yeah. So, and doctors can dispense also here, I guess. Yeah.
Yeah.
So over to Dr. Tufan Pati sir. Sir, for your comments and concluding remarks, since Amrit is stuck up somewhere.
Okay, thank you. And welcome, Dr. Jagadishan. I initially commented it must be midnight there. And yes, thank you very much for waking up to midnight. I have got 2 or 3 issues. And what we find in adult ADHD, persons in adult age having ADHD, there can be a group of patients who had ADHD in childhood, as it was told by Ruma and Sonia, that they had not been diagnosed and they're presenting in their adulthood. And there can be some persons who had different mental illness, but were subjected to nagging behavior, criticism, and some sort of marginalization by the family members, which occurs in India, and they are presenting with this, with a little destructive behavior, which we think is ADHD, because we do not know the real dynamics of their development. And one has to take another third condition into view. In India, out of around 142 crores of people in our country, around say 99.2 or 99.7 million people are having mental illness. And the mental health facility and the psychiatrists are only concentrated in urban areas mostly. So the single psychiatrist who stays in Ramgarh has to cater to the population which is much more in proportion to anywhere else in India. I don't think any system of any country can help him to look at the patients. Because Dr. Jagadishan as well as Dr. Abhi, they must be aware of Indian condition. These are the adverse things against which we treat. Imagine an OPD of 200 patients. You have to fix them up, or otherwise in periphery you are going to be bitten out if you don't finish them up. Nothing else. You may be bitten out. So you cannot go through these ridiculous things. So one has to develop a knack how to deal with it. And that is why maybe most of the patients in the childhood are neglected, because the primary focus comes up in curing the person who is the breadwinner of the family. Next, why ladies are less or ignored? Because health care receiving by women is quite less in case of the ladies, because of from their side, the family side, and the caregiving facility side. They have a very poor access to healthcare facilities in comparison to the males. So the dynamics will get in ladies in the adulthood will be much different. This is to clarify the scenario that what we get is a mixed bag, most likely it's a mixed bag of diagnosis. What we get. And then we try to come it and make them into different groups, which may not be certain. Maybe some of the cases will have the merits, should have the merits of Dr. Amit's considerations. Because we are seeing this, not the effect. And we are diagnosing ADHD. Initially, we gave to 1 or 2, 3 antidepressants, it didn't work. and methyl walk keto was reduced. This exclusive method may not be, but we do not have that infrastructure which all of us would have. Not with us, not with Sonia, not with me, not with Amit, not with Ruma, but the people who really are work at the remote corners, one psychiatrist going thrice a week and sitting from morning to night, maybe minting money, that is a separate question. But he is the only Messiah there. And next, my question, this was my comment, first was my appreciation. My question, is there any trial of neuromodulation in ADHD? This is a question.
ADHD per se, like obviously there are no studies on ECT, so it won't be make it more side effects than anything.
Any sort of neuromodulation?
Neurobiofeedback, there is some, but the data is inconclusive. And obviously TDCS, people use it as a cognitive enhancement, but the literature on ADHD is limited. So the area is very limited. That's what I can see.
Okay. Thank you, Dr. Jagdishan. We all of us sincerely hope that you have a good night's sleep. And if required, we may bother you to have one more sleepless night. And thank you.
Thank you, Jagdishan.
Thank you.
Thank you, ma'am. Thank you,
Shunia and Ruma.
Thank you, Jagdishan,
for being with us. Which quite rightly, we expect that you will be always with us. And Dr. Alim Siddiqui and Dr. Amit Joshi, who has gone out for some personal purpose. I do thank to them, thanks to all the participants who had been there. And now we have around 50 participants. And thanks to the Thursday music team. And thanks to Torrent Pharmaceuticals, which is giving us all academic support in this endeavor, which has reached this far. Thanks, everyone.
Thank you so much. Thank you so much. Wonderful, wonderful.
Thank you and good night.
Thank you, sir. Good night.
Thank you,
See
Jagdishan.
Good night, everyone.
Thank you. Thank you. See you.
Bye-bye.
Thank you.
Yeah, bye.
Thank you, sir.
Thanks for giving us the opportunity. Thank you. Bye-bye.
Bye. So we can close the meeting now?
Yeah, you are the host.
Shreya is the host. Shreya, please close the meeting.